Okay, can you still hear me out there, everybody?
Yes, we can.
Okay, thank you. Okay, well, Doctor Who's not here at the moment. He's in Alaska. He will be here hopefully for questions. Just post those in the chat room. Um, I also wanted to well, anyhow, I'm going to run this his presentation, and afterwards we'll be able to handle some questions. Um, but Doctor Who. Uh, as I said, from Alaska. I can't say enough about Jerry. He is very distinguished. Recently, he and Dr. Kamisi had done some research and published a article with published the results of the research at the Academy of General Dentistry. I could go on and on, but this this video on bite techniques could not be presented by a more capable person. So I hope you find this very useful and practical in your practice. So here we go.
Hello there, Wisconsin. My name is Dr. Jerry Hu. I am so happy today to be able to do this review of bite methods and customized oral appliance therapy in dental sleep medicine. Thank you so much for attending, and I'm really excited about this webinar. To start off with disclosures, I don't have any conflicting interests or any issues regarding this presentation. I'm not soliciting or advertising for any equipment or brand or company, and so thank you so much. This activity has been planned and implemented in accordance with accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the American Academy of Sleep Medicine and the Wisconsin Sleep Society. The American Academy of Sleep Medicine is accredited by the ACCME to provide continuing education for physicians. So generally, when I kick off this presentation in a live audience, I would ask an audience member about the question, can a dentist in North America diagnose sleep apnea? And the answer, of course, is no. You need a board-certified sleep physician to be able to do that. And then I would actually go ahead and talk to the audience about the importance of their opinion and their view and what we do as dentists. So when we think about all the side effects, all the follow-ups and everything that we do to excel in dental sleep medicine, they all matter, because as the patient returns to the board certified sleep MD or their primary care physician or any DOMD, what they expect and what they say and how everything in terms of their journey went will be disclosed to the MDs. If there is anything negative, we know that negativity spreads a lot faster than positive statements. So we really, as dentists, need to be sensitive and also very thorough in what we do. We have to respect 3D because 3D is who we are. We're not two-dimensional or one-dimensional. So as we go through the presentation today, please keep those thoughts in mind. And ultimately, it is linked and connected to the overall view, reputation, and the concerns that the medical doctors have towards dentists. So to continue, what's important for the MDs and then the people in the medical field, whenever I speak to a MD, NT, or pulmonologist, etc., we speak in terms of evidence-based. And I absolutely agree that evidence-based science is so important. And studies in dental sleep medicine always need to be improved and added upon. But with that said, I wanted to also discuss the reality of where we're at in sleep medicine and all the research that's been done. So I want to kind of quote Zaghi from the Stanford Sleep Medical Center, and he used the Oxford University Center for Evidence-Based Medicine, and he talks about really all the studies that exist in sleep. And so if we want to kind of get real, if you will, even CPAP studies and those that are available, most of them are actually level 4. And even when you look at tracheotomy, you're looking at level 2. So yes, randomized control studies are very, very powerful, and they are used sort of on top with those meta-analysis as research that can be attained. But I also want to express that randomized control studies are not cheap to do. They're very, very expensive, and good ones really take a lot of hard work to complete. So today we'll be reviewing definitely different oral appliance options, different bite options, and also orthotropics. And keep in mind, though, that a lot of these studies that are in sleep medicine, albeit they're case series or pilot studies or just initial on the bottom type studies, but they actually show physically improvement, quality of life improvement, side effect improvements, and things like that that are very, very important, and they are meaningful. And so we should not negate those studies that aren't randomized controlled, but very much should be always considered for us as dentists in dental sleep medicine. So when we talk about customized oral appliance therapy to patients and to other doctors, we come to the term of non-responder. So I have this photo of a guy that kind of has an expression like, "Are you kidding me?" And I really wanted to say that because first, when a patient comes to see a dentist, sometimes they have already tried a CPAP trial and they failed, so they're CPAP intolerant, and they really want to do anything and everything they can to help improve their sleep, their quality of life, right? So what we say, what we tell them, and the hope or the lack of hope that we give them is very, very crucial. Therefore, it is our responsibility as dentists to really look into if a patient truly is a non-responder to oral appliance therapy. I know there are some companies out there that actually look at one-dimensional only, the anterior posterior, the AP, and they actually do a requirement of telling the patient whether or not they will respond to oral appliance therapy. However, they did not look at other dimensions such as vertical or lateral, pitch roll, yaw, etc. And that's very, very concerning because oftentimes when you look into the different dimensions, as we are 3D, we're not two-dimensional, one-dimensional, you will not only find resolution and actually effectiveness at the therapeutic position, but you'll also find that it's more comfortable and patients likely to be more compliant. So it's very, very important that we give the respect that's needed for each individual patient who walks into our office. They have a three-dimensional presentation with them, and if we're only going to do one-dimensional analysis, we should not tell them whether they are a responder or a non-responder because it's a very powerful statement. Of course, if they truly are a non-responder, there are other options that goes from less invasive to more invasive. For example, orthotropics, craniofacial epigenetics, pneumopedics, or fixed osteogrowth appliances and whatnot. Those are out there as well. We will talk about that towards the end of the lecture today. But it's very important that we keep in mind that when you tell a patient that they can't respond, sometimes it's not only just a sad disclosure, it's also kind of a thing related to their hope and their ability to treat their airway issues. So I firmly believe in actual sweet spot. Like every patient who walks in has a position when considering all the different dimensions, lateral, vertical, AP, pitch roll, yaw, all of the dimensions, that there is not just a position that we know that we can show with post-efficacy sleep test results, but also that it's comfortable and it's really quote unquote meant for the patient, right? So we should have equipment. We should have things that are allowing us to measure. And I firmly believe that in science, when things are repeatable and measurable, that's scientific. However, everything else that isn't is just an opinion. So having the equipment, having a visualization, and actually measuring and taking the time to be meticulous about that is going to end up with finding a sweet spot. Sometimes after using everything we can and we cannot find it, then of course there's other options to look to. But most of the time when we look at different dimensions and we are meticulous in our behavior, we're going to find not just a therapeutic spot, but also one that is very comfortable. And with everything being said regarding that, it's very important that we go back to our Hippocratic Oath. We should do no harm as healthcare providers, but also every patient who walks in the door, we need to give it our fullest, our best potential within us to do the best we can for the patients. And so, and it goes both for medical doctors as well as for dentists. On the one hand, I hold the medical community very responsible in terms of their compliance with CPAP. CPAP, because when you're not using the CPAP, there's no treatment whatsoever. And you hear of cases all over, from celebrities such as Reggie White and to Justice Scalia even, where when you have an issue with CPAP compliance, the long-term effectiveness of that, if you will, it shouldn't be the elephant in the room that's never discussed. These are things that are life-threatening, and it's actually a very serious medical condition, right? So we need to be reminding ourselves of our oath. And as dentists, it goes along the same way. We shouldn't try to kind of have a factory conveyor belt system where patients come in and out, we take a one-dimensional analysis, make an oral appliance, and then say goodbye. These are real life patients that have, families and etc. We need to do what we had the oath when we got our degrees and graduated from school. So I want to please have you all think of this as we go through why it is so passionate for me to express that we have to be meticulous. We have to look at all the different dimensions and do what we can in terms of everything: communication, follow-up, mitigating side effects, the whole 9 yards. Okay, thank you. So a company actually did a survey of sleep MDs and pulmonologists, and they're addressing this issue. So for example, in 2018, there were 2 million people in the United States who were CPAP intolerant, but yet in the entire year, only 200,000 oral appliances are made. This is a very, very important issue, and it should really, really hit the center of your heart with that, right? Because when you have CPAP intolerance, there's already, of course, a medical diagnosis of sleep apnea. There's already a trial run of CPAP. There's already proof that the patient is intolerant and is not compliant with it, and yet they are still with the issue, the sleep apnea problem. But if they're not being referred to dentists, something is really, really seriously wrong with that picture, right? And so a lot of the MDs and pulmonologists with that survey, said that side effects matter when patients return and say if they have TMD issues, or if they have discomfort, or if they're, for example, protruded too far, or there is lack of follow-up. See, those things are very, very important. So there's another slide coming down that talks more specifically about it. But I want you guys to keep in mind that, yes, we've already established that the MD's opinion of us is very, very important. And hopefully in the future, we can change those numbers, those statistics around for how they refer us, especially when CPAP fails. So when we focus in on 3D and a sweet spot for a position in customized oral appliance therapy, we need to consider that there are multiple dimensions, which we just talked about, but there's also a lot of anatomical variations and conditions. We think about sleep apnea in terms of the upper airway, either as a garden hose, which is ideal, it won't collapse, or a fireman's hose, where when there isn't a peak rate flow, like a Starling's resistor, then the dimensions collapse. If you look at a standard fireman's hose, they're flat, but once the water goes through it, the pressure is there, it sustains its patency. So we got to think about the anatomy, the pharyngeal muscles, the vagal plexus of nerves, all of that, neurology, and that's very important when we're determining factors for sweet spot position. So I have some citations here that we talk about the different dimensions. When you're eating and chewing, you can see that our mandible can move beyond just, those border movements that are classical, the anterior, posterior, the lateral, vertical. We can chew things on one side. There could be a pitch, roll, yaw. Pilots, airline pilots, they know, or just a general plane pilot, they know about pitch, roll, yaw. And so we need to at least consider the 6 dimensions. There are, of course, more dimensions, but those things are important. And if we can have equipment to gauge and measure how that, it gives results in terms of patency of the airway or the collapsibility of the airway, it's absolutely essential. But also when people present with prior car accidents, or they have compensation all their life because they have poor airway, they have cranial strain, side bends, torsion, and all these cans. And if they're lopsided one way, well, maybe in finding that position, we need to assess, well, maybe if we have the oral appliance be a little bit more to the left or the right to give the ideal airway. It's very, very important to think of that. Think of 3D and think of the presentation, the full appearance of the patient, and test that and get measurements and base your therapeutic position off of that. In breaking down the anatomical factors, we're going to go through each of these in a slide format. We're going to talk about the size of the tongue, the buccal vestibular mucosa, TMJ and TMD issues, nasal patency, the sleep position, sleep hygiene, and talk about muscles and collapsibility. So when considering anatomical considerations, I always like to use what is currently being done in the world of implants. So whether you're looking at recommended methods for doing surgical guides, whether it be at AID or ICOI, they talk about looking at, of course, anatomy, vessels to muscles to bone to everything that we have to consider when we're looking at 3D analysis for implant dentistry, right? So when we take a cone beam, there's so much assessment. Of course, there's software that helps with the placement of implants and things. But we're, getting back to the basics and things of looking at a patient in 3D format. And why should that be any different for oral appliance therapy? So for argument's sakes, we should really do the same level of attention to anatomy and finding out the unique sweet spot of the patients for our oral appliance therapy. And while we're assessing anatomy, we should keep in mind, of course, that our entire body is connected. We should think very holistically. If a patient has a leg that's longer than the other, corrective orthotics, seeing SOTs, for example, or chiropractors, chirodontics, those things are very important. And yes, absolutely tied to our position that we assess for airway. And so just keep in mind that we should be, thinking of the entire body, not just, tooth doctors are focused on one area, but that it's all interconnected. So the first consideration would be the size of tongue, right? So if we have a huge macroglossia tongue that has all the scallop borders and the classical signs that we see and pick up during the examination, we should, when we think about oral appliance therapy, how much vertical can be a determining factor, not just for comfort, but for effectiveness. Of course, if you open the vertical component with the oral appliance and you get more room for the tongue, that will definitely address that. But also, when we assess things, we should look at not just the arch shape, if there's a micrognathia or whatnot, look for tori, look for those things that are around the tongue to actually give not just red flags, but how the design and the type of appliance and all those things are going to be planned for.
Thank you.
Next, we need to assess soft tissue and inflammation. So we know that if we're shifting from parasympathetic to sympathetic, and we have cortisol, cytokines, and everything that lead towards more inflammation, and then we talk about cardiovascular implications like hypertension and whatnot, the number one thing that we know that fights inflammation and all those issues is from our nasal breathing when we have nitric oxide developed, right? Sure, endothelial cell linings can produce a little bit, but mainly we get our nitric oxide from patent proper nasal breathing. So when we need to add in things, for example, rhinometry to look at nasal patency involving the ENT for septoplasty, for turbinate reduction, for any of those issues or whatnot, that's very important because we want to get a patent nasal airway. Moreover, when you do oral appliance therapy, there's no rule in the book that says you can't add on myofunctional therapy. So myofunctional therapy exercises are very, very important. I know there's a lot of different videos out there. One of my favorite sets are done by Audrey Yoon over at Stanford Sleep Medical. And she has so many different exercises available that you can show patients and share, but you can just pick three. For example, the button for the orbicularis oris muscle with the string, right? Or chewing gum and flattening out on the palate and doing that sound. Those things can be actually implemented and spoken to your patients to do in conjunction with oral appliance therapy, and that should help with inflammation. So when we look at TMJ issues and TMD, we need to think about all the presentations that a patient may come up with, and they're very important because if they come in with pain and migraine headaches and all those things, these are very important to look at. First, looking at the retrodiscal tissue, the bilaminar zone, seeing if there is any TMD, any derangement of the issues, disc issues and whatnot. Even looking at simple things like Eagle syndrome with that calcified stylomandibular ligament, that you can pick up on a panoramic, or looking at, we're using our cell phones so many times nowadays, their patient's posture, their alignment, the nuchal ligament, all those things ring in the ears. All those things are important, but also to keep in mind that there are neuromuscular options for orthotics. You can use ultra low frequency TENS, the Alpha TENS K7 machine, as well as, for electrosonography, EMG muscle analysis. But it's very important to know that those things are all out there, from the myomonitor to different tensing apparatuses that actually create an antidromic effect that allows a muscle not to produce an action potential and can truly rest, thereby finding a position in those in an orthotic, as well as dealing with muscle pain. Travell is one of the heroes of muscle pain issues, and recommend reading, of course, her text and her literature as well. But yeah, those are very important as we are, again, full body holistic dentists, that we connect everything together. So once again, we need to look at the nose. We need to look, for nasal patent breathing. Of course, nitric oxide is so important, but there are simple things from the Cottle test all the way to using rhinometry, which is also very simple and very useful in letting us understand if there should be an ENT referral. What that also creates is a good baseline, and then also a further development of a solid relationship between ENTs. It could be a back and forth referral basis, and it really does help the patient overall have a better airway outcome, being able to breathe through the nose. And of course, sleep hygiene and sleep position is very important. We do know that sometimes we find positional sleep apnea patients, and when you have a slumber bump pillow or a Medcline pillow, that would help. But also, knowing that there are also holistic medications out there, such as the exceptional nutritionals, even RADZ with 3 Z's. Those are all different things you can take to help with sleep, melatonin, all that stuff. But moreover, just sleep hygiene, knowing the proper temperature and not having cell phones or things around, those are all important. And it's important that when we talk about even oral appliance therapy, that those sleep hygiene recommendations are often discussed and patient is aware. So earlier, I also alluded to the fact that patients can walk in with prior car accidents, or they've been compensating all their lives and they have uneven shoulders, uneven ears, their posture may be forward, mouth breathers, they may have adenoid facies, they may have allergies, allergic shiners, the whole 9 yards. And so it's important to look at different modalities and work in conjunction with interdisciplinary methods, meaning that you get a chiropractor, an Atlas orthogonist, or a SOT, or a Rockabout physical therapist, because those things in conjunction with what we do in dentistry will make a difference, will make long-term successful outcomes. Also, you have to keep in mind that neurology, when you talk about loop gain and all these things, there needs to be a lot more studies, of course, into that. But just know that, like, for example, the vagus nerve, which is very long, the plexus, and they innervate the pharyngeal muscles, it's very important for us to have that concept and that neurology in mind, and also have an open mind to work with interdisciplinary other people that are very, very helpful and beneficial for the patient's overall outcome. Earlier, I also mentioned about, the 2 types of hoses, the garden hose versus the fireman's hose, about the collapsibility, about the P-Crit, the Starling's resistor, the flow that we have. And the point of this guide really is to underscore the fact that we should always do what's minimally necessary and not overdo it, but to find the collapsibility, to find the levels, and to see what we can do to maximally improve, but also not to do something. For example, on a CPAP, if you were able to find that a pressure of 10 or 8 is good enough, and any type of additional pressure added to the CPAP really won't make that much of a difference in the lumen, or the collapsibility, if you will, keeping the airway patent, then why would you want to have excess, discomfort or air being forced down? And that's going to equate to fewer hours of usage, or maybe even none whatsoever. And that's very important when we consider compliance and long-term success rates. So in connecting with the prior slide to this one, obviously I had a photo of equipment, because I'm very, very pro equipment. I'm a equipment's junkie. You can see that the collapsibility can be measured and it can be repeated. If we do a modified Mueller's collapse, in that we can see, what is needed, we can improve upon that using, for example, the pharyngometer equipment. In connection with that, the pharyngometer equipment can help us find our sweet spot. And so I always gave an analogy in the past of shoes, but I kind of want to shift to having my custom tailor-made suits done in Hong Kong. Just really quick on the shoe example, it really was in a nutshell that if everyone was supposed to wear size 10 shoes, I can't imagine, for example, my wife who loves wearing shoes and she went to Nordstrom's, for example, and the shoe clerk or salesman there says, nope, if it's too big for you, then enjoy limping along with it. If it's too small, then you'll have some calluses, but eventually you'll break holes through them. It'll be more comfortable. There's just no way that customers would accept that for shoes. But the customized tailored suits done in Hong Kong, I was so fascinated by how they did that. I mean, literally, they took pins and they were going, all the contours from my love handles to everywhere. But the suit really fits nice. It not only looks sharp, but it's comfortable and it's really being respectful to who I am 3D, my presentation, all the contours. And why aren't we that way in dental sleep medicine? We need to be, right? We need to be able to look at different dimensions. We always already know that 1 millimeter, and sometimes advocates like Dr. Stephen Galila would say 0.8 millimeters matters in sleep. It's been shown in the literature that yes, if we titrate, on those continuous advanced appliances, if you titrate a 1/4 millimeter, eventually you'll get to the sweet spot. Of course, you're calibrating back and forth with that, and of course, I'm going to talk about our method or trying to do the homework prior so that you don't have to calibrate so much. But if 1/4 millimeter matters, then yes, we should be very, very sensitive. Dentists in our minds, we already have the notion that if there's an open margin or if there's a small little overhang, we lose sleep over that. So we are already by design very, very particular, and we look in the micro world to make sure that everything is the best to our ability. So with a serious condition like sleep apnea, we definitely should be that, and probably even more. So I love giving those analogies that show that having respect for 3D and the specifics and the meticulous aim to get that position is so vital and important. So in 2019, AADSM gathered a bunch of dentists, and they were able to, ascertain what's important for long-term success and what oral appliances should be doing. So when we look at this, we're going to, in the next several slides, discuss this matter very, very openly. So from that AADSM report, it's very, very important. And again, it actually ties together for what I've been speaking about. If we find a therapeutic position and we take the homework and do all the things that we're supposed to be doing to work up to that, we need to make sure that that position is held. So maintaining that position is very, very important. Again, I can't underscore enough that even 1 millimeter can make a difference in sleep medicine. And again, if that weren't so, we wouldn't even calibrate. If it's just within the ballpark of 4 to 5 millimeters, well then heck, everybody can just get an over-counter device and not make it customized to the level that it needs to be with, sensitivity to even 1 millimeter of difference. That then ties into the survey that was done. And there was over 200 pulmonologists and ENTs that were asked, right? And so if you have an oral appliance that, you've asked the lab to fabricate for you, first you have to see if they translated that bite very, very accurately to the oral appliance. So, and in that, it's not just one dimension. It's everything from the vertical component to where it sits laterally, if there's a pitch or roll, if there's any type of cant or whatnot. All those things need to be accounted for. It's very, very important. Once that's established, though, we also need to make sure that things like, slop or other things aren't part of the equation, or major changes in the appliance material. We want to make sure that it is very precise and it holds its position, because, that is very, very important. Another thing, too, is if we are only looking at, certain dimensions and we jet a patient's out, to 100% protrusion, for example, it's going to create side effects. And those things, once again, when the patient returns to see the sleep MD or their primary care physician, it's going to give a bad outcome or a negative report to the physicians. Therefore, they may become more and more hesitant to refer to us. So we must, again, think of these things and be very sensitive in doing the best we can to mitigate and prevent any of those issues. So in oral appliance therapy selection, the first and most important, again, which connects to what I just said, is precision. We need to make sure that appliances are very, very precise. And they really should be milled, in my opinion, because when you're looking at CAD/CAM and looking at all those different digital printing and fabricating manufacturing of appliances, it's definitely different than handmade. And so having appliances that will give you exactly that position you asked for is absolutely critical. Some and most of all the oral appliances made in the past, they were all handmade, and you can understand that when you do handmade materials of appliances and whatnot, there's a lot of human error and issues that can come about versus something that's milled from a puck or something that is computer digitalized. There's a big difference in terms of the accuracy precision of what's being made. So when you are thinking about oral appliance therapy selection, you should really consider those facts that if it's handmade, it's also a very important notion, for example, to use. If I asked everyone to mount a case, let's say 100 people, 100 dentists, to find a CR bite and mount it on a semi-adjustable articulator, if I were to take a caliper and measure everybody's interpretation of whether CR bite on the same patient is or was, plus the way they mount it, by hand, you can find definitely that there are variations. So if you have something consistent, apples to apples with milled, it is definitely a big difference in terms of oral appliance fabrication. Also, whether impressions are taken digitally versus traditional PVS, that's important. Traditional PVS, we're looking at, accuracy in the 80%, 83, 84% range. But when you're looking at CAD/CAM and things like that, you're looking at 99.999, whatever, very, very high accuracy there. Also with traditional impressions, I live in Alaska, for example, and if the FedEx truck comes in the wintertime and my impression goes in the truck and sits there over 30 to 40 below weather, and then it goes to California, you can imagine there could be some distortion or shrinkage, etc., whatnot, as it comes back and forth. So having a digital scan is very, very helpful and useful. Which brings me to this slide of slop, because slop can happen whether it is the FedEx truck driver or the person making it by hand. Maybe they're tired one day or they did a lot of exercise and whatnot, and you can see maybe the accuracy or the result of careless handling and stuff can actually affect the outcome of that appliance. So please keep slop in mind. And of course, with the Medicare appliances, they have the Herbst-Arm. There's several things, there's some studies actually that show it's very irritating to the buccal vestibular mucosa. Again, that ties with compliance. But the main thing is there could be slippage. And so if we're, again, trying to maintain the therapeutic position that we've gotten, all the hard work we put into it, that needs to be held, especially for the elderly Medicare patients, which a lot of Herbst-Arms and TAP things are done. Slippage is very, very important to consider. And so the size and the overall bulkiness of the appliance very much matter. There's tongue space. There's things like, do we consider whether or not appliance could be made lingual-less? Those are very, very important things, because if it's not going to be necessary, it's only going to be taking up room in the airway. So I've done a study with one of the companies to look at bulkiness, and some of the appliances could be 3 to 4 times as bulky as the minimalistic appliances. So it's important that when we think of appliance selection, that we consider, what can we do for the maximum effect, but the minimalist size, or the least bulky, if you will. It's very, very important, because again, that's related to comfort and long-term compliance. Then I also think about this slide, the BioGunk, and I always joke around with audience members when I speak about this, that if you can smell the appliance just by looking at the slide, it's pretty gross and disgusting, and we need to consider the materials and things that we do. I tell my hygienists all the time to preach about the cardiovascular link with periodontal health, right? So if you have calculus, tartar, and bacteria on a patient who's been so overdue and they swallow it all the time. The literature shows that, of course, it increases the risk of cardiovascular issues and problems. So why would we have a appliance that has so much gunk in it and ask the patient every day to put it back in their mouth? To me, it's equally, hypocrisy, if you will, that we do that. So looking at the material, if it's a dense material such as control cure PMMA versus something that is very, very porous like nylon, those are very, very important considerations to have as well for oral appliance therapy. And I know that the University of Pacific did a study in terms of with one appliance company about tooth movement, right, in the appliances that we give, and they found that rigid appliances, the conclusion was there's hardly any movement, minimalistic movement whatsoever, if there is any type of movement. And what I mean by that is, they actually were able to look at a patient's presentation before oral appliance therapy, and then a couple of years down the road, take another scan and overlap it to see if there's any changes or movement, comparing it to the Little's Index and Rose's paper and ortho literature to see how much movement there is, and to be able to say that rigid appliances that are available to hold teeth position, that's almost like better than the best of Bavaria retainer in ortho, right? We're holding the teeth in the position that they are, and that's very, very beneficial in terms of appliance selection as well when they're rigid. Now that we have briefly touched on the oral appliance selection and the respect for 3D, we're going to shift a little bit to the various bite techniques. And again, I just want to be very neutral about what I'm saying. I'm not here to advocate only one method or whatnot, but I do think that different bite techniques should be measured. There should be equipment to assess, ascertain whether or not it's a good position to be held at. Also, if there's any type of dynamic treatments out there, orthotropics, it's also good to use equipment to measure progress and to gain that understanding and also communication feedback to patients and to the physicians that they are working with. So the most widely used, of course, bite method in dental sleep medicine for customized oral appliance therapy would be the George gauge. And so I'll say some pros about it. Number one, it's very, very cost effective. It's not very expensive. There's 2 bite fork sizes that you can get, but it's really an AP anterior posterior method of gaining a bite. And once again, earlier when we talked about how important it is to respect 3D, the other dimensions, this absolutely really doesn't take into account incremental vertical measurements. And so there's kind of a pros and cons with that. I do understand that most people in dental sleep medicine are just using this, but again, I believe that we owe it to our patients to look into other dimensions. So with this slide, I have to say that I have uttermost respect for Dr. Remer, Suresh, the people at Zephyr Matrix. And I want to say, though, that yes, this was done in the one-dimensional anterior posterior. And yes, there are times when they told patients that the only way they're going to be responding is if they're 90 to 100% protrusion. But the whole concept of this and being able to do it during sleep, as well as not just in the sleep center, but with the Plus system, people were able to do it at home, like a home sleep test. I think it's very fascinating. But once again, to be truthful to what I believe and who I am today after getting into dental sleep medicine, looking at literature, I really think that other dimensions has to be assessed. Now, again, I know people in the AP world always use an old study from Sister Lee Van der Viken that talks about only 2 vertical dimensions that's assessed, one at 4 millimeters and one at 14 millimeters. And I find it very troubling because incrementally, again, when we talk about sweet spots, there should be multiple different positions assessed, not just for therapeutic value, but also for comfort and things like that, also for side effects. So long story short, I think this is a great idea. This is also done during sleep. Very respectful of the randomized control studies. But again, especially when you're telling a patient that they're a non-responder and you have not looked at other vertical aspects, I think it's very, very concerning. Here we're getting into a little bit more about the dynamic bite methods options, and I really have respect, of course, for the Moses system and the kinetic kinesiology that's done with that. Of course, you have different shims that you use, and you're putting pressure and looking at the patient's strength and posture and all of that, which is great. A negative side is the naysayers can say that's a lot of subjectivity, but I'm telling you, even when we did those things for NTI where they bid on a straw or a toothpick or whatnot, and having different strength and ability to overcome pressure or forces, it's phenomenal. So this is a very, very important and option to consider. Once again, though, I think whatever is taken in this bite method should be analyzed in other equipment. How does the patient feel? For example, if they have TMJ issues or pain, get the K7 equipment out, or get the neuromuscular equipment that you have, or how well does this bite show in terms of a Mueller's collapse on the pharyngometer. It's very, very important, again, to get information and measure. And with the swallow bite, that's also dynamic. Generally, patients get the neuromuscular workup. It helps you find the vertical, and you just go up and down, close into the wax. It helps establish a vertical. But once again, it's subjective, but it is, however, very, very cost effective. As you can see, just getting these wax rims is all you need for the swallow bite. And for the Phonetics S-Bite, the sibilant phoneme registration, this is a pretty awesome method. I know Dr. Steve Olmos has really mastered one of, taking a phonetics bite. Of course, he looks at motor reflex testing, seeing whether or not things are primary in nature, secondary, and then doing it in proper treatment and order. Very, very essential, important. I can also say a good colleague of mine, Dr. Jeff Harrison, was there with Dr. Olmos. And again, the bite that was taken when vertical was added to it and assessed, vertical different increments, the bite taken can even improve substantially, 2 to 3 times is what I was told when Jeff was there. So it's really a cool way to ascertain not only a good bite for airway, but also to see, primary, secondary, and motor reflex testing. Very, very valid and awesome manner to do a sleep bite. Then, of course, there's a neuromuscular bite, and there's equipment that you can use to not just get patients into a relaxed state, again, with the ultra low frequency TENS, but also to capture a bite. There's also really improved ability for us to look into types of orthotics. I know the Myoaligner company with Miriam over in Oregon, they offer this really fantastic digital system to have sectional orthotics and things that just really are fantastic in bringing the neuromuscular world to even greater heights and better long-term effectiveness. I did again, this is not a randomized study, but it's actually a study on one patient. So it's a single patient, but I try to remove all the variables so I can compare apples to apples. I know I haven't talked about the pharyngometer bite yet, which comes in the next slide, but I wanted to share this study where I had the same patient, okay, and I took 3 different bites. I took a George H bite, a neuromuscular bite, as well as a pharyngometer bite. For the neuromuscular bite, again, I tensed the patient, and I looked for EMGs where they're the most rested. I know there's different names and types of neuromuscular bite. For example, if you were to go to LVI, there's a tag bite, 5-second bite. There's a whole slew of bites. But I'm just looking simply at a bite that's neuromuscular that shows the EMGs are rested. And then I also took a pharyngometer bite doing modified Mueller's collapse and seeing the best effect that I have at different positions using the airway metrics jigs. And then, of course, I compared to the George H bite. It's not surprising that the results came out when I thought they would come out. And first of all, I used a precision milled appliance with controlled cured PMMA, so it's very accurate, it's precisely milled, right? And so it's the same appliance company on the same patient with the same digital scanning for the bite position. Then looking at the post-sleep test results, of course, the least favorite, the least effective, and actually the most uncomfortable and potentially side effect driven would be the George gauge bite. The interesting thing is that the neuromuscular bite and the pharyngometer bite were actually relatively pretty good in terms of how they responded on the two equipment. So on the pharyngometer bite won. It did the most improvement in terms of cross-sectional space in the airway. And on the neuromuscular system, the EMGs, the muscles were most relaxed, of course, in the neuromuscular bite. However, the pharyngometer bite was not that far off. The pistons on the EMGs weren't bad. Of course, neuromuscular was better. But my point is the patient came in without TMJ issues, without TMD. So therefore, we ended up with a pharyngometer bite. But the reason why I say that is because if the patient, however, came in with a lot of TMD issues and they had pain and muscle pain or etc., it wouldn't hurt again, especially when we measured, if you will, on the pharyngometer that the neuromuscular bite was also pretty effective. Not as effective, but pretty effective in that position. So that's some food for thought. Now, with the apnea guard, that's, again, I get into more of what I really like and hope that the future of dentistry and sleep medicine look into. So Todd Morgan developed the apnea guard, and it actually adds the vertical component, and you can look at different incremental levels and gauge that. But I also would, again, test that position, whatever it is that you find in apnea guard, just to make sure on the pharyngometer you see that there is a valid improvement in cross-sectional space and the collapsibility of the airway. And then a few years back at the American Sleep and Breathing Academy, I know Dr. Singh, not the Vivos Dr. Singh, a different Dr. Singh in New York City, developed a program that uses the Andra gauge with a system that takes the CT scan. It's very, very thorough. There are pages of questions to ask about measurements and things that you pick up on the cone beam. Then it actually spits out an XYZ, meaning an anterior, posterior, lateral, and vertical component. And then combining that with the Andra gauge and getting a good oral appliance made that position is very effective. So this is definitely on the right tracks for the future of dental sleep medicine, also respecting 3D and airway. And of course, last but not least, I wanted to talk about the pharyngometer bite. So again, I can't stress enough about measurement and about using equipment to gauge everything from progress or to find a therapeutic position. And using the airway metrics jigs, I really believe that it's given the respect that the patient deserves. We're looking at incremental assessments of how well the patient improves with collapsibility, looking at vertical, looking at anterior, posterior, looking at even lateral. The pharyngometer is the equipment. It doesn't have feelings. It doesn't have emotions. It's there to give us coordinates, data, and that's very important because we can measure, repeat, and we can do a system where we have the patient sit in a certain way, and then we have them continue to sit and posture, everything all considered, and then we can see, well, what does a different position in the mandible create in terms of outcome. And especially when you look into vertical and other things like that, you'll see that there's a significant difference in terms of your therapeutic position, the comfort, and long-term success. So Dr. John Commisi and myself, we did a peer-reviewed case feasibility study, and I'm so grateful that it's out in the Academy of General Dentistry's peer-reviewed journal. But really, we know that in all the different schools of thought or camps for TMJ training, TMD issues, we always learn that vertical is a lot more forgiving than AP, anterior, posterior. So that makes a lot of sense. I mean, if you were to jet someone's mandible forward 100% and expect them to not have side effects, I mean, we're looking about the whole retrodiscal tissue area, the disc, the whole TMJ, area, very, very innervated, highly sensitive, and AP definitely is less forgiving, especially if we jet out people too far. What the study was able to conclude was that when you respect vertical, just adding that one extra dimension, sometimes you can save up to 4 to 5 millimeters of protrusion, which again means more comfort, better compliance long-term, and greater successful long-term outcomes, right? But also the fact that Other dimensions need to be looked upon. I think this paper is hopefully an encouragement to have further studies done with all dimensions. This was a 30 scheduled patients back to back. It's a consecutive feasibility study. 2 of the patients moved out of state, so they're of course excluded from the results. We had the 28 people follow through. So I'm really proud of this publication, and I think it helps serves the need to look into vertical and other dimensions. So with all the given statements and different options, I'm very passionate about dental sleep medicine. I have my own dental IP patented things, and the Who Verifier is going to be, soon to a theater near you. Actually, it's going to be through prototype, and the proof of concept has already been done with that. But of course, beta testers and things like that will be needed. But it really will allow for us dental sleep medicine dentists to look into pitch, roll, yaw, anterior, posterior, lateral, all the 6 dimensions that we were talking about, in addition to verifying the bite prior to the final fabrication of the definitive appliance. So it's important that we do the homework up front. It also looks much better rather than calibrating left and right and back and forth so many times. I live again in Alaska, and people live remotely at times, driving 50 to 60 miles easily to come and see me, and I can't imagine if I had to go back and forth so many times just to calibrate an appliance, versus doing everything up front, using equipment to gauge into a sweet spot, and then having a lab that accurately represents that sweet spot into the oral appliance that's fabricated. I think that's really the future of dental sleep medicine with customized oral appliance MRD treatment. So the last 2 slides, I'm going to talk about that when you've already done everything you possibly can to assess all the dimensions and to look at everything that you can for customized oral appliance therapy, and you truly have a non-responder. Then, of course, we have to look into other options. And once again, this is where I want to talk about the evidence-based slide, that although there aren't so many randomized controls, etc., for these different options, but there are many clinical studies and case feasibility studies, and you really see videos and people and after cone beam, before cone beam, to ascertain that, hey, this is definitely an option. Because once again, if they've already CPAP intolerant, if the patient's already CPAP intolerant, as well as they're a non-responder to traditional customized oral appliance therapy, it's very important to open up different options that I have myself and other dentists have seen, literally change people's lives, not just help with their airway, but their whole quality of life, their energy, the whole 9 yards. So I wanted to start first with by saying that a lot of white paper, like Dr. Steve Galila has now with the Facial Beauty Institute published these huge white paper, which is awesome, right? Showing over 8,000 cases they've done with sleep apnea, with TMD issues, growing and expanding the palate and the airway. So it's not to be taken lightly. I think that's awesome. And I know that Dr. Singh with Vivos is also working with Stanford and Mayo and a bunch of other, I think, Midwestern University, and getting a collaboration on a meta-analysis as well. So please don't dismiss any of these options, because they are real. They're real in my life, and I hope that patients in situations where they're looking for some alternatives, or if they're non-responders, to please consider. Now with Chirodontics, that's with Bob Walker. He's a chiropractor, and it's really awesome because he does really manual treatment. He's looking at the occiput, looking at the alignment, again for cranial strains, looking at how people will present themselves, and they will be with or without pain, but they have no idea really how much alignment and how much symmetry that can be done, as well as their occlusion in their bite. Bob Walker, when he teaches, he doesn't allow chiropractors to go to seminars unless they bring a dentist with them, because he understands that after all that manual work, as soon as the patient swallows and bites and gets into the routine compromised, status, everything's going to fall back and fail. So having the orthodontic component, having the occlusion component, and the dentist component is very important with the chirodontics method of treating airway and TMJ, TMD. With the craniofacial epigenetic pneumopedic De Vivo system, it's also something that's a fantastic option. And the one thing I really have to say about that is that it really is very biomimetic. It's at the pace of what the body wants to do. I think anytime when we introduce our own version, whether you're an orthodontist or just a general dentist, applying pressure to different appliances and forces that may go beyond what the body wants to do in terms of its rate change, you can run the risk of certain side effects like inflammation, root resorption, dehiscence, and sometimes even relapse. So very, very radical or invasive treatment options may conclude with relapse and those things that we don't want to see. So although the system with the DNA appliance, for example, requires the patient to be very compliant, and sometimes it's over a year or year and a half, sometimes even 2 years, but it does respect the body's pace at change and movement, which again minimizes relapse and those other side effects that's mentioned. Now with the Osteo Growth Guidance Appliance, that's in Controlled Arch Ortho, that's with the Facial Beauty Institute with Dr. Stephen Galella. This is a awesome option, and it not only do you get a very detailed report, which would fascinate and impress any medical doctor, any ENT. You do this assessment with photos, with cone beam, and there are his patented ways to look at that, to take into consideration everything from a car accident to a side bend to all these different presentations that you would get in order to do a case with the Facial Beauty Institute. But very, very fantastic option to look into for patients with airway and TMD and growth issues. Then, of course, you're getting a little bit more invasive with the maxillary skeletal expansion from Juan Moon at UCLA. These are microimplants up and through the palate to the nasal area, and actually creating a very wide palate. You will actually have a diastema at the conclusion of this, and then use ortho to close the spacing. But one thing sometimes that you see in long-term studies, if there's any relapse, it is maybe because there's a lot more forces. And of course, when you get into dome, micro rapid palatal expansion, surgical assisted rapid palatal expansion, the MARP, SARP, and the dome, you're going to have more invasive options with that. But again, there's a lot of literature that show and back up success rates with that as well. Of course, there's Inspire, but it's very important that people know there's criteria for Inspire. It's also not the cheapest option out there, but if you have a lateral collapse, you have a certain BMI index, those are things that are important to consider for Inspire. There's also the MMA, which is actually done quite a bit in Asia. They do the maxillary mandibular advancement, but that's very, very invasive. And the way I feel about surgery is, it's irreversible. If something goes wrong, then we have the issue with that it's irreversible. And of course, there's tracheostomy, and that's if you want to talk like this, and the patient's all right with that, that's an option to consider. But definitely, please consider these things as tools you can have for patients if they are non-responders and failed CPAP. And for kids, I really hope a lot more seminars in, for example, like AADSM, ASBA, ACSDD, all of those talk more about kids and children options. I always think of, it's really emotional because I don't think any parent out there wouldn't do anything and everything for their kids. And if they're going through school and they are being labeled with ADHD and this or whatnot, and they're given drugs which pretty much are like speed, like Adderall and Ritalin, it's just really, really sad, because if the root cause and the root problem is really an airway issue, and they're giving all this medication, which is pro-big pharma, we really need to consider these different choices. And when I see kids, the most rewarding thing is when they improve. Not only am I happy about the outcome, but the parents, they're looking at you in the eye and they're almost in tears. And that's the effect that we have, that we can give for our kiddos, right? So it's important that we look at those options that are out there. Of course, the Facial Beauty Institute has the removable osseous guidance appliance. It's a really neat system. You ask the kid to do a journal and to work along in compliance. You have these little little, not only do you bond with the patients when you do this, but you really see improvement in their school performance and their sports and things like that. It's just fantastic. With the Vivo system, I even used it on my own son, my third son, as young as 2.5 years old, with the starters and the guides. They're just phenomenal because they have recommendations in conjunction with myofunctional therapy exercises, and really the kid becomes thriving and doing so well at school. Again, of course, other choices such as Orthotain, which is now Healthy Start, or MyoBrace, they also have success stories as well, and they should never be overlooked because they're very, very valid choices. Also, again, when we're looking at development and we're looking at the progress, the growth, if you will, whether or not a child's thriving, working with nutritionists, working with other interdisciplinary professionals is so adequate, so important, excuse me, and of course adequate, right? Certain lifestyle things, quality of life matter, and having that discussion, having that option available. So I really encourage people from the seminar to look into these orthotropic options, because that could be life-changing, life-saving, lifespan expanding with that. So very much please don't overlook these options. So I want to conclude, and first, thank you very much for listening to this webinar. I want to say that there is over 1 billion with a B people in the world who are underdiagnosed, undertreated with sleep breathing disorders. And, you know, this is very, very key, passionate drive of mine to be able to do lectures, and it's sort of a calling for me. And I believe that together, we as dentists, doing things meticulously, respecting 3D, and doing everything that we can to provide for our patients, our Hippocratic Oath, all of that considered, I really am happy and honored that there are dentists even looking at this and using videos such as this and presentations throughout the world, gaining dental sleep medicine traction. Very grateful for that, and thank you again so much.